Um, and well, let's get right into it. And I'll say a couple things to start. First, I'll try to tell you when I'm giving you an opinion, and I'll tell you when I'm giving you a fact. Okay? You don't get to have opinions about facts. Okay? And so there are a lot of opinions, and if you're looking for my slides, I was the negligent one. I didn't have them there. So you're going to have all of these, but I'm afraid you're just going to have to sit and listen. And the second thing I want to fess up right here now, there is no such thing as a marijuana treatment. So I'm going to be talking to you about substance use disorders, of which marijuana is among the most prevalent. Okay? And if you fall asleep in the middle of what I'm saying, please remember this one, because this has a lot to do with everything that we're all talking about. And what it is a picture of what substance use looks like in the United States. It's a pyramid with low levels of use, very small levels of use at the bottom. And as the further you go up, the more use you get, the more intense, the more severe. Now, you all know these guys. These are the Charlie Sheens, the Lindsay Lohans of the world, okay? But this is very important. Down here, most people think the United States has the worst drug abuse problems in the world. We don't. Poland and Russia now have that distinction. What we do have is the largest proportion of people in the world who do not use any substance at all. There are more people who don't drink in this country than in many Muslim countries where it's illegal. All right. Now, your keen eye should show you a wavy line here with dots in it. That's where substance use disorders start. And it's wavy because we don't know exactly where that line is, what level of frequency, intensity, duration, etc. And there are dots in it because people go back and forth. But that's where it starts. But, big deal, there's 40 million of these people. 40 million? That can't be. I don't see 40 million people stumbling down drunk or using. No, you don't. These are the kinds of disorders that are significant. They affect productivity, they affect relationships, and very importantly, they affect crime and health. This is one of the reasons that we have the Affordable Care Act, and substance use disorders are an essential service. It's not because of these guys. It's because of these guys. These guys screw up the onset, the management, the course of every chronic illness that there is. Still don't quite get what I'm talking about. Okay, let's take a young woman. She drinks 2 drinks a day. Okay? Now, she drinks every day, but 2 drinks. Otherwise, good health. There's nobody in this room imagines that she is an alcoholic. She's not. Now I tell you she's pregnant. Oh, wait a minute. Now we got a problem. That is a substance use disorder. That is harmful use. It's the same frequency duration, except that it's quite harmful, indeed toxic, to the fetus. All right, that's an extreme example, Tom. Give me another one. Same woman. She's got a history, a very significant history of breast cancer. That is still harmful use because alcohol is a better predictor of likelihood of getting breast cancer than even smoking is. If you've got it, any amount of alcohol accelerates tumor growth. Point. It is the beginning of substance use disorders. You've never heard about this because we ain't got no insurance plan until 2014. We ain't never had no insurance plan that ever covered it. It's like you wouldn't have heard of diabetes, pre-diabetes, if the insurance plan had only covered people who lost their fingers or lost their eyesight from diabetes. That's what we've always had. All right, let's keep going. Let's go further up the pyramid here. You see that nice, bright, crisp line? Now you're in Charlie Sheen territory. This is the most serious of the substance use disorders, abuse and dependence, commonly called addiction. There's about 23 million people, adults in this country. By the way, this does not include cigarettes. It's every drug other than cigarettes, okay? And yes, marijuana's in there. In comparison, you all know there's a diabetes epidemic in this country. Well, there's only about 24 million diabetics. So yes, we have as many people with the most severe form of substance use, addiction, as we have people with diabetes. Now, if you're in the back of the room, you can't even see this orange pinnacle that I kept referring to. That's the number of people who get any kind of treatment. 1/10 of this group, right? But a tiny fraction of this group. Worse, the treatments that are quite appropriate for the most severely affected people are not appropriate, not attractive to all of those people. So right away, I'm trying to set the stage for you as you think about marijuana. We have a problem. We have a treatment system that doesn't fit the illness, and I'll go more into that. So how are you going to do that? And by the way, I hear this all the time from Congress people. Actually, nothing works, does it? We don't have any really effective treatments. No, that's not so. What do you mean works? Let's be specific here. What is a medication or an intervention or a treatment that might work, and what would that look like? I got a good idea. Let's take the Food and Drug Administration criteria for effectiveness. We have the safest medications, the most potent medications in the world. And they require 2 randomized controlled clinical trials and or a very large population study before they will approve a new medication, a new diet, a new device. That keeps your kids safe, okay? So with that status and with that criterion, can we say that we have any effective treatments for any substance use? And the answer is yes. Here are some of the behavioral therapies that have been shown to be effective with 2 randomized controlled trials. This is just some of them. There are actually 16 that meet that criterion. And you keep saying it's a medical disorder. Patrick Kennedy keeps saying this is public health. Do we have any medications? Yep, we got those too. You know about the tobacco medications. I have these in green here because they're available through your doctor right now. And yes, they are working right now on a nicotine vaccine. Here's medications that are currently available for the treatment of alcohol and opiate disorder. Happy to talk about them, but just for the sake of time, I want to get to the ones you're most interested in. Cocaine I have in yellow because these medications have been shown in 2 randomized controlled trials to be effective, but it's not yet available. You can't go to your doctor and say, I need that topiramate for my cocaine problem. And yep, they're working on a cocaine vaccine. Not one you would give a child to prevent them from ever being able to get cocaine dependence. But if you get cocaine dependence, this vaccine is a competitive blocker and will prevent you from feeling the effects of it. It's in the works. And now we're into, excuse me, marijuana and methamphetamine. We do not yet have medications that have been shown to be effective in the treatment of either of those. There is one drug in Europe, rimonabant. It's been used in the treatment of cigarette and methamphetamine, marijuana dependence, but it's not available, and the data are spotty. So, okay, if you're keeping score so far, we got a lot of people with substance use disorders. We have a lot more that have substance use disorders than have addictions. We have effective behavioral therapies, and we have several effective medications. So we're in pretty good shape, right? No, we're not in pretty good shape at all. We got a big problem, and the problem is the way we have always thought about addiction. Addiction until very, very recently, certainly the turn of the century, has always been perceived, even within medical establishment, as a bad habit. Antisocial behavior, poor parenting, poor character, just bad protoplasm, okay? And our treatment has always reflected that. And so, as a good colleague of mine has always said, the United States has never been able to make up its mind as to whether addiction is an illness or really bad behavior. So we've compromised. We'll give them treatment, but it won't be any good. And that's what we got. We've got the only treatment today, excuse me, if your kid gets marijuana addicted, and please, again, I'm not giving you opinions here, your kid can get marijuana addicted. Your kid gets marijuana addicted, cocaine, opiate, alcohol addicted, they're going to a specialty treatment program today. They're not going to your primary care doctor. Your primary care doctor doesn't know anything about it. He's never been trained in medical school, okay? And at specialty, thanks, Sue. At specialty care, there's about 12,000 of these. They are paid for, they're not even paid for by health insurance, predominantly paid for by your state block grants. So in a very real sense, the substance abuse treatment field has been segregated, quite purposely segregated from the rest of healthcare since its inception in the 60s, okay? These programs are small mom and pop, not-for-profit shops. A lot of you are public officials. You've probably been invited to, quote, graduation ceremonies. You've been there. They're all hugging and crying, best of luck, all that stuff. Just a note, diabetes, for example, doesn't have graduation ceremonies. You don't hug people and say after 30 days, good luck, Billy, you know, good luck with that diabetes. You don't do that because it's a chronic illness and it's treated way differently. Well, we've never done that. So these places are very small. And from a commercial standpoint, they don't have the money, they don't have the manpower, they don't have the ability to implement any of those evidence-based treatments that I just showed you. Remember all those behavioral therapies I put on the list? Remember all those medications? You won't find them there. Why? Because they are ideologues or they're stupid or something? Nope. They just aren't structured. Most of them do not have a doctor or a nurse. Those that do, it's part-time. The great majority do not have a full-time psychologist or a social worker, anybody who could give responsibly any of those really more sophisticated behavioral therapies. The major active ingredient in the treatments in Washington State and in Oregon and every state is counseling. Counselors in all states do not have to have the kind of backgrounds that other healthcare professionals have. Now, they're a dedicated group. They're trying very, very hard. But the pay is poor, the working conditions are poor, and you got 50% turnover rates. They have about the same turnover rates in treatment facilities as they have people who make the beds in this hotel. Point. You know those sophisticated behavioral therapies? You know those medications? You know all those other interventions that could be delivered? You're not going to do it if you have a workforce that's going to turn over twice a year. You're not going to implement it. And so they're not there. Oh boy, that's bad news. Why is that? Has this been purposeful on the part of legislatures around the country? Is it purposeful because we want to punish substance abusers? No. It's how we've always seen the problem. The problem's always been bad habit. A patient is a bad guy. He doesn't understand drugs are bad. He's got to be taught a lesson. And so we created a treatment plan and an insurance package and a way of evaluating that has assured stigma. Okay? Here's the standard diagram for how your kids would get treated today. I say this with some certainty because that's how my kids got treated. It's a washing machine model. You take a dirty old substance user and then you put them into Shady Acres treatment program. I don't care if it's a residential one or a methadone maintenance or a outpatient or whatever. It's time limited by design. And then the issue has always been, what goes in the washing machine? Is it a certain kind of a therapy? Or no, maybe it's a certain kind of a regulation or an accreditation package. Or now maybe an evidence-based practice. It's always been time limited. And right about here, there's the big graduation ceremony after 12 sessions or 30 days or whatever the benefit is. Now there's discharge, followed by a guy like me evaluating the effectiveness of treatment. 6 months or 12 months later, I come around and interview these people, see if they're using drugs. If they're using drugs, treatment failed. They aren't using drugs, hooray. Well, that assumes that there is some fixed amount type duration of care that would actually fix the problem, sort of like a cast on a leg. It also assumes that you're going to be able to make the maximum benefit if you could just place the right kind of patient in the right kind of treatment. And it assumes that the effectiveness ought to continue as you go through the rest of your life. You send Charlie Sheen to Betty Ford, give him 30 days, he'll learn his lesson, have an epiphany, straighten out, he'll be straight for the rest of his life. Well, how'd that work out, by the way? That's sort of interesting because, you know, most of the rest of medicine doesn't treat things like that because most illnesses we can't cure. We can manage, but we can't cure them. And for chronic illnesses like diabetes, like hypertension, like asthma, like all of them, you don't want to discharge them. You may be getting calls right this evening from a nurse saying, how are you doing with that medication we gave you? Are you watching your diet? Remember, you've got an appointment with your physician on Tuesday. They love you, they care for you. That's not why they're calling you. They don't want you out of the skinny, inexpensive end of treatment. Because if you do, you're going to relapse. You're going to put on weight. You're going to stop taking your medication. You're going to cost them money because you're going to show up in the ER. Okay? Right. And now, let me tell you why that makes a difference about how you think about addiction treatment. And if you're saying, so I still don't get what this has to do with marijuana legislation, get ready. Our organization evaluates substance abuse treatment all over the world. We do, like there are financial companies that do financial due diligence. We do clinical due diligence. We're working with 5 venture capital firms right now that are actively looking for places to put marijuana treatment in your states because they know there's going to be a boom, okay? We're trying to guide them as to what to buy, how to set it up, okay? So let me tell you why it makes a difference how you see the illness. Here is a set of data for a drug, a hypothetical drug. You guys are members of the Food and Drug Administration. You're hereby deputized, okay? Your job is to decide whether we put this drug into the market so that your kids will have it, okay? Now, the illness is hypertension, and here's the data. Here's the symptoms before treatment starts, right? Now we give them the new drug or the new intervention, or we give them the new whatever diet, and now we evaluate them after. Now let's just see how it works. Okay, look, we got it big. I mean, I'm a trained scientist, so I can tell you this bar is a lot bigger than those bars, okay? Symptoms are high before treatment starts. But look, once the medications or the diet or the intervention start, the symptoms go down. You know what? Food and Drug Administration says that is one kind of evidence I'm going to use to approve this medication. So far, so good. But wait, there's more. Look what happens when you take the medication away. The symptoms come right back up. Food and Drug Administration takes that also as evidence for effectiveness. So, you know what? I think we're going to pass this one. Good. Congratulations. You've got a brand new medication in the treatment of hypertension. All right, let's go to the next case. Now, many of you will notice a similarity between the last case and the first case. No. critical difference. This is a new medication for cocaine addiction. This is a new treatment for marijuana addiction, okay? But Tom, the data are exactly the same. So I guess we'll pass this, right? It's a trick. No, we're not going to pass this. Are you kidding me? Can't you see that the symptoms 6 months or 12 months after treatment is over are practically the same as they were before? This treatment is a failure. Oh, I see. You were looking at what goes on during treatment. No. We never have done that in the evaluation of substance abuse treatments. The expectation has always been send them to treatment, give them an epiphany, put them on the right road, discharge them, they'll be good forever. So I've done hundreds of these evaluations. I've come to the same conclusion, and I've been wrong. Okay, great, Tom. That's so much for your career. What else have you got for us? Substance use disorders, in case you're not keeping score, range in severity, okay? You're going to need treatments for kids who are using too much but are not addicted. Kids who are losing concentration. You heard what Dr. Friedman said. He's absolutely right. You have not done yourselves a favor by making availability higher. And you may have reduced some harms. That's, as the president said, that's to be determined. But you're going to have greater availability. You're going to have more. This is a fact, folks. You're going to have more kids using. Definite. Not all of them will get addicted. Many of them will have symptoms of other problems. Now, you're going to need different kinds of treatments. Once they do get addicted, they're not going to have a curable illness. This, too, is a fact. Again, I want to make that clear. I'm not giving you my opinions. They're not going to have a curable illness. They will have a manageable illness, but you're going to need a treatment system that doesn't give acute care for a chronic illness. Okay? Now, we've never been insured that way. How in the world are we going to do that? Well, some of you may have heard about this. It's probably escaped your attention. It just made passing comments in the news called the Affordable Care Act. And the Affordable Care Act takes treatment away from just there. That's the only treatment we've ever had. You could never get insured, you could never get a medication, you could never get an intervention, and a doctor could never get paid for it if your condition were down here. Only here. Okay? Yeah. What's the current benefit in addiction? Here's the Medicaid benefit in your states. Okay? You get detoxification. Opioid substitution therapy is like methadone or buprenorphine. Only about half of the states do. And they monitor the course of it, but you only get 7 urine tests per year. That's pretty skinny monitoring. And it's not really crazy considering that most people are in treatment for less than 30 days. Okay? Wow. What do you notice about that benefit, that insurance benefit? Well, they're program benefits, for one thing. You've got to go to a treatment program. You can't go to your doctor for that. Very few options. I showed you the whole thing. Not much effort there to make care attractive. Almost as though you haven't made up your mind whether addiction's a crime or an illness and you don't want it to be very good, all right? Well, all right, I sort of get what you're saying, Tom, but like, what do you have in mind? Well, let's take a real illness. Let's take diabetes. What's the benefit look like in your states today? Here's what it looks like. First of all, as I say, I'm a trained scientist, so I can tell you there are more things on here than there were on the last slide, okay? And they are fundamentally different. Notice it's visit this, visit that, visit that. They're visits. You get physicians, nurses, other forms of clinical practitioners get paid if they visit you in your house, if you come to the clinic, if you go to the office space. All FDA-approved medications, all kinds of tests that monitor the effectiveness of care. Get this, you can get smoking cessation in your paid to get treatment for smoking cessation if you got diabetes in your state, but not if you're addicted. Okay? Even if you don't know the language in, I don't know exactly about your two states, but you can get an interpreter to help you. And it's communicating something beyond the fact that there's more stuff there. It's fundamentally different. Most of these are primary care benefits. They're visit benefits, not program benefits. And it's almost as though they're trying to engage the patient into care, make it attractive, give them options. You know why? Because they are. So it's cruel of me to just show you how different things are without telling you. I'm going to buzz through that. What you just saw tachistoscopically there was the Affordable Care Act. But here's the good news. Substance use disorders are an essential element. You can't have a health plan without substance use disorders. That's never been the case. The reason? $120 billion in wasted primary and regular care because of failure to deal with substance use disorders. And here are the benefits that are projected. This is still, now I'm not giving you facts, I'm giving you my latest information. Wow, it looks sort of like the diabetes benefit. Yeah, thanks to Patrick Kennedy, as a matter of fact. The Parity Act has assured that people who have illnesses that affect their brain are going to get approximately the same type, duration, and kind of care as people who have illnesses that affect the rest of their body. So, the bad news is that we've been thinking about and treating and insuring substance use disorders the wrong way for my adult life. Treatment started in the 60s with the advent of the baby boomers using marijuana and other drugs, and just exploded into the Vietnam veterans returning with opiates. But we only decided to treat the top. This is the coverage you're going to get. And the good news here is, as you will hear from other speakers, we can prevent substance use. There are many effective community-based treatments, many developed in Washington State, as a matter of fact. You can intervene effectively in people who have emerging substance abuse. Notice the words I'm using. Use is different than abuse is different from addiction. You can treat addiction as well, but you need a chronic care model as is appropriate for other illnesses that look like it. Illnesses that you can manage but not cure. So, this country is going to start thinking about this differently, and it's going to be on your doorsteps earlier than it is in others, because you're going to see more substance use disorders. You're going to see them at an earlier age, and my strong advice to you is to amp up the prevention and early intervention elements, because they're the least expensive and they have the most enduring effects. That kind of care will be different than care for the most severely addicted. There are good scientific ways to do it. And the patient-centered medical home, which is all primary care doctors know about now, is going to have to be modified and adapted to it to take alcohol, marijuana, cocaine, and opiate use. So, sorry for the very rapid run through there. I give you hopefully some indication of how to think about substance use disorders and addiction. Happy to answer a few questions if there's time.